Hello to you all, ladies and gentlemen, the community in Dental XP. It's my privilege and honor to be here to do a presentation on Dental XP, and I'm going to be speaking to you about newer techniques that that have developed over the past few years for developing aesthetics in the anterior zone. I come from the city of Bangalore, Bengaluru as it's known right now, which is a vibrant city in the south of India. And as you can see, we have a lot to offer from the cultural to the technological point of view. And Bengaluru is probably the new Silicon Valley of the world as we would know it. And we are also home to the Implant and Aesthetic Academy India in collaboration with Dr. Havik Lakman of South Africa. And it's been a great association having Dr. Maurice Salama and Dental XP to collaborate with over these years. And once again, it's a proud privilege to be out here to speak to you all. Immediate implants, I think, are probably something that is being practiced routinely all over the place, and you can see that starting from single teeth in the maxillary anteriors to the mandibular molars to a full mouth reconstruction. It's something that that is being practiced in all areas and all regions of the mouth. And it is being practiced with a certain degree of predictability, as we all know now from literature that they fare as well and probably better than implants that are done in a delayed manner. The problem with the anterior aesthetic zone and implant therapy is that of the bone loss that occurs, which is an obligatory bone loss following tooth extraction, and this is something that we constantly are struggling to circumvent. There have been techniques that have been developed in the past which have tried to overcome this problem, but not entirely successfully. There have been studies that demonstrate these marked alterations that happen, that take place in terms of height and width of the alveolar bone, which occur following single or multiple tooth extractions, starting from Lekovich et al. In the 1997 to 98, all the way through to Schropp in 2003. A kind of landmark article in the last decade or so is this one by Araujo and Linde, which in the Journal of Clinical Periodontology in 2005, which discusses dimensional alterations following tooth extraction as an experimental study in the dog. And we find that this the reason for the amount of dimensional change that we see, particularly bone loss on the buccal aspect of an extraction socket, has largely been related to the presence of bundle bone on the facial aspect, and this bundle bone comprises a large part of the buccal wall of the socket. And the modeling of this bundle bone, once extraction takes place, results in the amount of vertical and horizontal bone loss that takes place. Interestingly, a systematic review of post-extractional alveolar hard and soft tissue dimensional changes in humans by Nicholas Lang and his group in 2012. Actually, they did a large database survey to come up with 238 abstracts in 3,900 plus articles, and they found only 20 articles that actually met the inclusion criteria. More interestingly, these landmark articles by Araujo and Linde did not make the grade, and they were not included in this study. However, the conclusions of the study were that horizontal bone loss of between 29 and 60% and vertical bone loss of between 11 and 20% takes place after tooth extraction. perhaps a more pragmatic and more you know easier way to try to look at dimensional alterations after extractions in humans is by the use of technology that is available to us these days, and that is the cone beam CT scan. And Chapuis and Buser's group, they worked with the same technology, with the assumption that having a thicker bone type would result in a less amount of bone loss than if the facial plate was thinner in dimension. And they did find that facial bone wall thickness of less than 1 mm was a critical factor in the kind of dimensional changes that would be observable over a period of time. The Cochrane database published in 2015, in May of 2015, concluded that there have been techniques that have been employed in the past for alveolar ridge preservation, but these techniques have not really influenced, or it's not very conclusive, the kind of influence that these techniques might have in the overall changes in residual ridge height and width, particularly at 6 months after extraction. And there does not seem to be any clinical evidence or convincing evidence of differences in techniques or biomaterials that are used for these alveolar ridge preservation procedures. Which brings us all to the to look at a few other aspects that have been studied, and that is what happens when you do an immediate implant. There was an assumption in, when Lazara first reported that you could place implants into extraction sockets, that was a paradigm shift in the way implants were practiced. Implants were a lengthy treatment process till the 1990s, when the first time there was reports of immediate implant placement. Now, the assumption in the 90s was that if you placed an implant into an extraction socket, you would prevent bone loss. This also extended to the application of large diameter implants to try to plug the entire socket with an implant of an appropriate diameter. We know that that is not the way to go now, and the rules of the game as far as placing implants immediately after extraction are different, and we are trying to generate a gap between the labial plate of bone and the implant body itself. Botticelli assessed the dimensional alterations that occurred in the alveolar ridge during a 4-month period after extraction and immediate implant placement. And in this 4-month interval, he found that the buccal bone dimensional change is close to 56%, and the corresponding reduction of the lingual or palatal plate wall was only 30% in comparison. Araujo and Linde again looked at the tissue modeling after implant placement in fresh extraction sockets, again in the beagle dog, and there have been several other studies which have dealt with this, and all have come up to naught in terms of trying to preserve bone, and the conclusions are very similar, that there is going to be ridge alterations once extractions and implant placement takes place in an immediate manner. A human study using cone beam CT scan by Fabio Rossi and his group from Italy, published in the International Journal of Resto Perio, found again that the alveolar buccal bony crest undergoes substantial remodeling, but none of this remodeling actually affects implant integration. However, the long-term consequences of this bone loss might have disastrous and deleterious effects on the aesthetics of those implants. And so let's just take a look at this case to see what happens when we install an implant immediately after extraction. You can see this right lateral incisor, which is fractured, and the patient has had numerous attempts at having a post-core done on this tooth, and then it was beyond restoration. So went ahead and did what is known as an atraumatic extraction, that is by severing the periodontal ligament fibers using a periotome, and you can see the intact bony walls and the kind of soft tissue that is there, as well as the intact bony wall on the facial aspect. It's a photograph that depicts this in clear clarity. And I also would like you to appreciate the dimensions, or the buccolingual dimensions of the extraction socket, and therefore the facial plate. This is an implant, the twist drill in the right three-dimensional position for the implant placement, and that is after placing the implant and having grafted the gap with a particulate graft over here. Now you can see that the jumping distance is well over 2.5 millimeters, and you can see that there is a land of more than 3 to 4 millimeters on the facial aspect of the implant, close to 5 millimeters if you look at the prominence of the buccal plate to the implant body itself. Now, with all this implant did not achieve adequate primary stability for immediate provisionalization. So this was, I placed a cover screw, and we had just put a collagen plug on top of this and provisionalized with a bonded temporary. And when I went back in 4 months to restore this tooth with a provisional, what you can see here is the kind of rich collapse that has taken place despite the placement of the implant being in the three-dimensionally right position, despite the amount of bone graft that had been placed into the jumping distance. And this is a photograph that will demonstrate the dimensional change as well as the contour change that has taken place with time. With the provisional in place, and after second stage, when we've done a little bit of connective tissue roll back with a palatal roll to try to bulk up the facial aspect again, and that's the bonded provisional once more. And the final restoration over here in PFM, and you can see how much of bone loss has actually taken place, or at least contour deficiency that has actually taken place on this on the facial aspect of this implant. Now the bottom line over here is that dimensional loss of bone after tooth extraction is absolutely obligatory. This bone loss is irrespective of whether you've raised a flap or not, and whether an implant is placed or not, or a bone graft is placed or not at the time of extraction. Even with all the given parameters in favor of immediate placement and restoration, the behavior of the buccal bony plate is unpredictable in the sense that it is very difficult. You may assess the biotype, you may assess you may have a great jumping distance, you may have a thick bony plate, but at the end of it, there is no way that you are going to be able to tell which ones of these patients are going to collapse and which ones of these are not. All of this indicates that ontogenically the buccal plate, and more specifically the bundle bone, belongs to the tooth, and the removal of the tooth will result in loss of bundle bone by virtue of loss of blood supply to the bundle bone via the periodontal ligament and the surface remodeling of the cortical plate to a certain extent. So what are the possible strategies that we have that are available to try to minimize these contour defects following immediate implant placement? One of them is an interesting technique which is known as the dual zone therapeutic concept, which was proposed by Stephen Chu, Maurice Salama, David Garber, and Saito. This basically involves an extraction, installation of an immediate implant, and grafting of the jumping distance in not merely the bone zone, but as well as the soft tissue zone, and stabilizing all of this or sealing this environment up by use of either a provisional restoration or a healing abutment of an appropriate diameter and shape to contain the graft in place. So let's take a look at a case to demonstrate this particular concept. And you can see that this is a central incisor which has been extracted and an implant placed in the correct three-dimensional position. That is, it is 3 millimeters subcrestal to the crest of gingiva, about 1.5 mm, 1 mm subcrestal to the labial plate of bone. Now we've got a provisional that has been made and polished, and now I've put a cover screw on top of this implant to now slowly push in. And if you'll see that what we are using here is not a condenser type of an instrument, but a flat perioprobe sort of an instrument to gently push the bone graft material into the bone gap and not really condensing it. The idea is to have enough porosity over here to allow angiogenesis to take place. You can see that we've overflown this into the dual zone, that is not only the bone zone but as well as coming over onto the onto the soft tissue zone of the extraction socket, and we screw the screw retained implant crown down. And as I push the crown down, you can see the extrusion of the excess bone graft material. This is immediately after surgery, and this patient went away, and this is the immediate post-op radiograph. She went away for a period of she came back at 2 weeks for a checkup, and then this is the state that she was in at 2 weeks after surgery. She came back at 6 months for her final restoration. At this point, I separated those two crowns that were there, that were splintered together because the neighboring tooth needed a crown as well. You can see the maintenance of the crestal bone levels over here. We separated the crowns and went ahead and made, removed the implant crown. And you can see the kind of submergence profile that has been created here. It's a healthy bleeding gingiva peri-implant mucosa out here, and you can see a sharp pointed papilla. So there has been great preservation of soft tissue architecture in all dimensions, and this is her final screw retained restoration being inserted. What I want you to look at is this zone out here, which is marked by the circle, which shows a dark show through, probably of the implant body, probably part of the crest module of the implant. Let's take a look at it from a profile, and you can see that there is some degree of flattening of the contour out here. And again, when you look at it from the occlusal or incisal aspect, you can see that there has been a considerable change in the contour of the facial aspect of this on this implant. This is despite there has been really no bone loss. And when you take I looked at a cone beam, you can see that there certainly is 2 millimeters or more of bone on the facial aspect of the implant. Despite this, there has been a loss of contour. And this is about a year later, when you can see 1 year post-loading, you can clearly appreciate the kind of loss of contour that has taken place on the side of the implant restoration. What this says to me, and the message that it should convey to everybody, is that despite all efforts, these alterations of bone and soft tissue around an implant, and the very dynamic nature of bone and soft tissue around implants makes it very unpredictable to say which are the ones who are going to collapse and which are the ones who are not. There have been several other techniques. Some of the notable techniques are the use of a bilaminar subepithelial connective tissue graft for immediate implant placement and provisionalization by Joseph Kahn. This is an interesting technique which does not seem to have too much literature on it yet, I mean, I'm not too sure how far it has been successful in other hands, because we've not heard of more groups reporting on this. But this technique essentially involves creating a buccal tunnel and packing in a bovine bone graft material into the tunnel to try to prevent buccal bone loss. So this takes us back to techniques that were employed in the past to try to conserve bone around, I mean, to conserve bone in all dimensions. And one of them, which was employed way in the past for various reasons, starting from the 1960s, was the root submergence technique, which saw a renaissance of sorts in 2007 when doctors Maurice Salama and Henry Salama, along with Dr. David Garber, revived the procedure to try to create pontic sites around, I mean, where multiple implants were involved or between multiple implants, to try to prevent or to create adequate emergence of those pontics. And just to illustrate the technique, I'll just run you through a case. You can see the right central incisor here is, I mean, it's a vital tooth which was going to be a pontic site. It could not have been restored while she was going to get a bridge on the other teeth. So we went ahead and cut it down to the level of the gingiva. Here I'm using a red stripe football to bevel the buccal side of the root stump down, and you can see that I have reduced the root stump to just about a ½ millimeter above the crest of bone and well below the crest of the gingiva. Now I go back to the palate and I make a rotated palatal pedicle flap, which is otherwise known as the VIPCT graft, and this is rolled over or rotated over the root stump, and you can see in the photograph on the left hand side that the root stump is vital and it's bleeding pulp. And here we've rotated the palatal pedicle over, created a small pouch on the facial, and stabilized this pedicle on the facial aspect, and that's closure. Now, this was done in April 2015. This patient lives elsewhere, and so she needed a long-term provisional, and she went ahead and got a provisional made in porcelain fused to metal to be replaced with something better at a later point in time. And so she is back in town now, and soon after I'm back, she will be treated to get her final restorations in place. But what I want you to see is the right central incisor and the maintenance of soft tissue architecture over there, both in the buccolingual and in the mesiodistal dimensions. Now, this is, I mean, this is a great technique to maintain soft tissue architectures and you know, to maintain the bony architecture around a hopeless tooth. The problem that we have in a situation like this is that edentulous site has no functional application, in the sense that now because the root is submerged there, you've got great bony prominence, you've got the soft tissue in the right place, but you cannot install an implant in there or do anything else. So it becomes only a site for a pontic. That's the only possible means of replacement of that missing tooth. Now, if you were to extend this philosophy to trying to retain a part of the tooth, which is what the philosophy of the socket shield is, you would, oh yeah, let me just take you back to this, and you can see the submerged root here. So if you extend that philosophy to retaining a part of the root to maintain the contours of the bone and buccal soft tissue, you have a technique that can and you can get osseointegration to implants placed into a socket of that nature, you probably have a winning combination in hand. And this is now there have also been other reports and studies or reports in the past, like those by Davarpana and Serge Moncler, where they placed implants inadvertently into or adjacent to retained root stumps. They also placed implants with purpose into the roots of impacted teeth, then unintentionally left behind root fragments in proximity to dental implants. Series of cases were also published by the Laureen Langer in the International Journal of Resto-Perio, all of which showed that implants can survive next to retained roots as long as there is no infection in the site. Now, a proof of principle study was first published by Marcus Herzeler, Otto Zur, and their group in the Journal of Clinical Periodontology back in 2010. And it described a technique of leaving a sliver of tooth root attached to the buccal aspect of the socket to preserve the periodontal ligament vasculature to the bundle bone and to prevent its collapse. Now, as from a logical standpoint, this seems to be, it seems to have all the trappings of a good technique for maintaining this facial bone. This is the article that Herzeler and Otto Zur published. This was followed up by one of Herzeler's students, Daniel Baumer, and they showed some histological evidence of what happens to these shields when they're in contact or in proximity to a dental implant. And you can see in this that their conclusions were that you get bone formation or a bone or cementum-like material that forms between the implant and the socket shield itself. And this has also been described as dento integration by some people. Now, this is probably the largest data available at this point in time with respect to human cases, and this is a large case series which has been published by Siampras and Kotsaki's group, and they've followed up 46 patients with a mean follow-up, with a median follow-up of 40 months and a range of 24 to 60 months. They have found that this technique helps to maintain, from an aesthetic and functional standpoint, the facial plate and the soft tissue architecture around it. This was also, now they've tried to, they named the technique the root membrane technique, and now they're trying to change the name again to something known as the PDL, mediated ridge preservation, for immediate implant rehabilitation in the aesthetic region. Irrespective of what it is going to be called eventually, the technique, the fundamentals of the technique remain the same. Now, this particular group, as well as the group of Marcus Herzeler, actually used the implant osteotomy drills to go through the root and to thin out the root on the facial aspect as well, and then went ahead and extracted the palatal half of the root before placing an implant in the palatal to the buccal fragment. Dental XP has a great video by Dr. Henry Salama showing a case of an ankylosed tooth where he's done much the same thing. This technique seems to have, in my hands, I would be a little skeptical about using my implant osteotomy drills through through the tooth for two reasons. One is the amount of chatter that the implant drills do create, as well as the kind of the wear that those implant drills are going to undergo when cutting through dentin and cementum. So there are some of us who use different techniques, and I know for a fact that Dr. Howard Gluckman, Dr. Jorge Campos in Spain, we use high-speed drills with the root resection burrs of a long shank to achieve the same end. Gluckman wrote an interesting article here in the International Dentistry African Edition, Volume 5, where he reviewed the available literature on the socket shield. And this is a list of the articles that is out there in literature as of 2015. This body of evidence is actually slowly growing. If you take a look at the evidence pyramid per se, the evidence that is available for this technique, be it the socket shield or the root membrane or whatever it is that we're going to finally call it, the evidence ranges in the case reports and case series and ideas and opinions, in that realm, and it is not a very high level of evidence. But clinical experience, I mean, we know that this evidence has to be tempered with the clinical experience, and we know that clinical experience across the globe, with numerous people publishing cases and showing case reports, the evidence is just growing. I think a little more structured studies on a few more structured studies on this, multicentric studies, would go a long way in establishing this as a standard of care or a protocol to be followed with immediate implants. I'm just going to run a short video. It's about 4 minutes long to show the technique as I do it. This is a maxillary right canine which is fractured, which had a crown. It has been there's been a post core, and this has kept fracturing, and there is no ferrule left, and now we are going to have to get this out. So here I am using a cervical matrix to shield the buccal gingiva, the labial gingiva, to reduce the facial aspect. And now I'm using a long shank burr, which is the H24 LE314012 from Brazil, to actually resect the root in the mesiodistal direction. So labiolingually we are separating the root, and that's the drill that I use in a high speed. We can now apply a luxator to the palatal aspect at one of the palato-proximal line angles, and you can see that the palatal fragment has come loose without loosening the facial fragment at all. All I'm using now is a mosquito artery to take the fragment, the palatal fragment out. Once we've got this out, we're going to go back in. That's the socket with the socket shield left intact on the facial side. And now we're going to go back in with our implant drills to create the osteotomy palatal to the socket shield. And that's the lance drill to make my initial penetration. And all the while there's going to be a palatal bias to try to be able to get a screw retained restoration in as a final restoration. And I'm going in with my final drill before I install a 4 by 13 mm implant on the palatal side of the socket shield. All along we need to make sure that I like to keep my socket shield away from, my implant away from the socket shield enough to make sure that there is no contact between the two, so that inadvertently there is no dislodgement of the shield. I'm checking now to see the palatal, the relationship to the palatal plate, and here we've got adequate insertion torque. You can see the gap that has been left between the shield and the root, and the implant. I've just placed a plastic castable on a metal base, and I'm going to now use this to make a custom healing abutment. I notch this on the facial side so I can relate it back, and you can see the notch out there on the facial aspect. So we take this off, and I'm just going to apply a little bit of flowable composite, bond this on, and create the emergence that I would like to have for this particular tooth. We take this off, finish it, and that's the implant in place with the socket shield. And you can see that in place with the healing abutment. And this is what it looks like at 2 weeks when he comes back for a follow-up. And 2 weeks later, this is what he looks like. This is another case that was done in August 2015. The socket shield and this particular provisional were done as a demonstration during a course. Now this lady disappeared for the longest time. She had a free tooth in her mouth, so she just did not show up. And when she came back in this kind of a state. She had no maintenance of any sort. So this is just after I'd cleaned up. We'd got some hygiene done for her, and then we got the provisional off. You can see that the shield is completely covered. You can also see that there is great bulk to the facial aspect of this implant. What I want you to look at over here and look at with a little critical eye is that this particular tooth, when I actually cut it down, I have in fact left part of the apex behind with a little bit of the gutta percha. Now as long as this does not get infected, this is fine, because this was a year after the procedure was done. The initial procedure was done in September 2014. All of these pictures were taken in August and September 2015. We went ahead and when she came back for a recall, you can see the healing that has taken place around here. And once again, when I got the provisional off, you can see that we've got a great emergence and submergence profile for this particular socket shield tooth. Now I went ahead and made another provisional this was generated in a lab. Also did a build-up on the neighboring tooth. Now once again this lady has disappeared, so this is a provisional restoration that she is with, and this is a screw retained composite fused to metal. And till something happens to this, I don't think I will be seeing this lady again. But this is what she looks like, and this is what the radiograph looks like at over a year later, right? And you can see how well the bone levels have been maintained, and the soft tissue outcomes are out there for you to see. Let's take, over the past few years, I have been practicing socket shields for a little over 4 years now. And over the last 4 years or so, I have seen, some interesting cases, some cases where we are able to make and draw comparisons between the socket shield, and doing a dual zone, and seeing some old implants placed with different philosophies of the time. So just take a look at this case. This was done in September 2012. She came with a fractured left lateral incisor. That's where the fractured incisor is, and we went ahead and I sectioned through the tooth, took out the palatal component, and we've been left behind with the socket shield on the facial side. Implant placed on the palatal aspect of that socket shield, and that's the implant in place. You can see the gap that we've created. I do not personally fill this gap because I expect this gap to fill with bone. I know that several other operators, including Harvey Gluckman, like to put a bone graft material into this space. As of now, I think this is going to be more of a personal choice matter rather than something that is backed by evidence. And I believe that by not putting anything over there, I'm really not losing anything either. So this is the implant position, and you can also see right now that there is an implant crown on the canine, the tooth adjacent to it, with which doesn't look altogether healthy. You can see right now that the peri-implant mucosa around that canine implant is not the best that there is. This is immediately after placing the implant. And at this point I decided not to provisionalize because I had adequate stability but not something that I was comfortable provisionalizing. So I went ahead and placed a healing abutment, and we used a removable denture, a flipper with an ovate Pontic, which was shaped to make sure that there was no impingement on the buccal side of this implant, and this is how she walked out of the office. When she came back in December of 2012, this is the kind of healing that we had. You can see the shield is completely covered in soft tissue. We went ahead and made her impressions and restored her with a screw retained PFM crown. In this particular photograph, now you can see very clearly the kind of problems that she's having with her implant restorations on the canine and backwards. Now those were implants that were placed over 10 years before she came to me by another doctor in another city. So this is December 2012. In August 2015, I got this photograph. She came back to me in February 2015, having fallen and broken her right lateral incisor. Harvey Gluckman was going to be in town to do a course with us, so we thought this would be an ideal case for him to demonstrate an immediate implant placement along with connective tissue grafting simultaneously with implant placement. So in March of 2015 or April of 2015, she went through a procedure for the right lateral incisor where an immediate extraction and implant was done in the lateral incisor area. Now if you will notice on the slide, I have marked some of these implants as 1, 2, 3 and 4. 1 is the maxillary left canine, 2 is the maxillary right canine, 3 is the maxillary left lateral incisor, and 4 is the maxillary right lateral incisor. I would like you to observe these 4 different implant restorations because all of them are implant restorations. Our implant, all of those 4 have implants around them, and in those areas. And you can, I would like you to look at what has gone on around these 4 implants. In the position number 1, that is the maxillary canine on the left hand side, you can see that there is a considerable recession of soft tissue, and we've lost considerable amounts of soft and hard tissue over there, enough for you to see the abutment and perhaps some part of the implant out there. In position number 2, where again there is an implant placed with a GBR, this was a delayed implant. You can see the amount of bone and soft tissue that is available on the outside and the maintenance of contour. 3 is the one with the socket shield that I had just shown you before, and 4 is what was done with a dual zone technique. This is back to the canine, and you can see that the tooth number 2, 3, The implant has been placed over 10 years ago. The implant is placed too far facially. So this was how implants were placed then. We realize now that implant positions and three-dimensional positioning of implants is better understood now. And you can see the amount of loss of bone and soft tissue around that implant. Tooth number 2, however, is the maxillary right canine, where an implant has been placed and a bovine bone graft has been used for GBR around that. And if you go back to Uli Grunder's studies from 2005, he talks about having a minimum of 2 millimeters or 2 to 4 millimeters of bone on the facial aspect for aesthetic longevity. And you can see that 4 years on, this particular tooth is performing as well or better than anything else. This is the socket shield, which is 3 years old at this point in time that you're seeing it. And you can see the shield out here, and you can see how well it's maintained the soft tissue architecture for us. This is just a comparative of all those implants at the same time. We went ahead now in tooth number 1, 2, or the right lateral, and got the healing abutment off and went ahead and placed our restoration. The contour of the restoration is giving you the impression, and the tooth number 1, 2 or the right lateral actually has a good emergence right now, but the phenotype of the gingival tissue over there, the blanching and the whiteness comes from the fact that tuberosity connective tissue was used in this region, and that is what is causing it to look much whiter. And I want you also to look at the bone levels that have been maintained around these implants, and despite the fact that all these implants are adjacent to each other, bone levels, interproximal bone levels are excellent and very, very stable over time. Let's take a look at another case. This was in December 2013. This gentleman comes from about 3,000 kilometers away, but he came with a general state of disrepair, a lot of breakdown in his dentition. The maxillary incisors, one of them was certainly marked for extraction. The other one he wanted to hold on to for as long as possible. So the right central was root treated, and we did a post and core on that. On the left central, however, there was really not too much hope because there was already a subgingival restoration. So we went ahead and did a socket shield on that. Okay, that's the shield in place. We've got the palatal fragment out, implant placed in the right three-dimensional place. And you can see that the implant is placed palatally and towards the distal corner of the socket with a gap between the shield and the implant itself. Placed a large healing abutment, and he was on his way. He went away. He went back to his hometown because there were several other teeth which needed to be restored. We made a provisional bridge in heat cure acrylic, and that was his provisional for this time that he was away. He came back 6 months later, and this is what things looked like at that point in time. We went ahead. The healing abutment had come loose, probably from the pressure, and I had probably not talked it down at the time of implant placement. But the healing abutment having come loose, there was a little bit of peri-implant mucositis over there, which settled down, and soon after we took this off. But just to put things into perspective, this was in December 2013, and in May 2014, with the socket shield in place, you can see the shield outlined over here in this radiograph. We've got excellent bone and soft tissue levels, and I went ahead and restored this tooth. This was in May 2015. He came back in August 2014, sorry. He came back in August 2014 for a recall. And now again you can take a look at how well the soft and hard tissue volumes have been maintained on this particular tooth. And we got a cone beam CT because he also needed a few other implants in the maxilla. So I managed to get a cone beam done, and you can see that in the coronal aspect, the socket shield has held the bone levels up, and we've got outstanding contours over there. In May 2015, after a misadventure with the chicken bone, this person broke his right central incisor, and he came to me looking like this. So I first thought I would attempt another socket shield here. Now this tooth had already gone through a lot. It was broken down pretty badly, and by the time I managed to separate the fragments and elevate the palatal, I had lost the socket shield portion. So I pulled the whole thing out and then went ahead and placed an immediate implant in a more conventional manner, if there is any such thing. And that's the implant in place. At this point, I used calcium phosphosilicate putty to graft the gap, and placed a large healing abutment to seal the environment. And he got a flipper on top of that. I did not want to give, after his previous misadventure, I was not willing to give him an immediate provisional. So he was sent with a removable flipper on top of this. And I want you to look at the kind of contour that is there right now. He came back in a month later for some reason to Bangalore city, and he came in for a checkup, and you can see that at this point in time everything looks hunky-dory. There's good bone, and there's good soft tissue volumes on the facial. When he came back in December of 2015, and I want you to look at what happens in the 6 months from June of 2015 to December of 2015, and there is a perceptible loss in the dimensions of soft tissue out here. Okay, not in the vertical dimension, but in the horizontal dimension certainly. We went ahead and gave him a screw retained restoration. There is a lack of papilla, but more importantly, you can see that there is a loss of the facial contour on the dual zone side, while the contour on the socket shield side is maintained brilliantly. So this is what he looks like now, and we'll wait for a while and we'll see how things go. This is another case to demonstrate the difference between a socket shield and conventional immediate implant placement. These were placed simultaneously 8 months before making this image. And the one in the anterior, the first premolar is with the socket shield, and the one in the posterior is without. Okay, and this is what it looks like with the crowns in place, right? And this is a cone beam to show you the shield and its maintenance of the hard tissue architecture around the socket shield implant. While if you look at section 79 and 80, you can see that there is barely a buccal plate around the implant in the second premolar region. So all of these cases, just to highlight the benefits of doing a procedure of this nature. What are the other applications that you can think of, one could think of the socket shield? And one of them is this publication by Glocker, where he uses socket shield for ridge preservation and delayed implant placement. And just to complete this, I will run you through another case which shows, so this is a case with mandibular anteriors which were broken down, periodontally compromised, and we were, both the laterals, one of them had been root treated and had a post-core. Periodontally, it was not in such a bad shape. The two centrals were periodontally compromised, they needed to go. The left lateral was also broken down, and there was just no way that we were going to be able to hold these teeth in place. So I went ahead, and you can see the cone beam here. And in the cone beam, you can see that around both the lateral incisors, there is barely a labial plate to talk about. Okay, so we went ahead and socket shielded both the lateral incisors and went ahead and placed implants lingual to them. This is an interesting case for what follows after all of this. Implants had great primary stability, so these were provisionally restored, and she was sent away. And she came back 4 months later after having the provisional dislodge in another place. She went to a local dentist who did something for her, and when she came back, and I went in to retrieve the provisional restoration, I got one of the implants failing. The lower right mandibular lateral incisor implant failed. So at this point, what I did is I took the implant out and we just curated the socket, but I left the socket shield behind. And this is what she looked like at about 8 weeks of healing after having lost the implant. She came back in 8 weeks, and I decided to flap her to see what was going on inside, because I was pretty certain that I would have to do a formal GBR around an implant over here. And when I took out, now you can see that I'm removing the socket shield that had been left in place to start with, and that's the shield out. And I have enough bone now to go ahead and place an implant in the correct three-dimensional position with well over 1 millimeter of bone on the facial aspect. But you can also appreciate over here that there is a small defect left behind from where the socket shield has been removed. So if the implant is placed, and we go ahead and do a formal GBR, do a periosteal release, GBR with an allograft and collagen membrane, and closure. I bonded on a Maryland bridge and sent her on her way. And this is her final restoration 4 months later. And this is what it looks like. What I wanted to look at in this view is the kind of maintenance of the facial contour around the socket shield implant, which is on the right hand side of your screen, and the GBR implant, which is on the left hand side of your screen. And you can see that though when you see the cone beam, you will see that though we have adequate bone on the GBR side as well, the kind of soft tissue contours that we have maintained around the socket shield side is far better and far more remarkable. And this is what she looks like, and you can take a look at the cone beam here. On the GBR side, you can see bone of about 1.5 to 2 millimeters on the facial aspect, and the 23, 24, and 25 are the socket shield side, and you can see the shield over there, and the sort of maintenance of architecture around the implant in that area. So what are the contraindications and potential complications of doing this technique? And I would enumerate the contraindications as if you have a tooth that is suffering, that is experiencing periodontal disease at that point in time. Now you can't have a tooth with periodontitis left behind and expect that an implant would integrate behind that. So those are not teeth that you can use to do socket shields with. I would be a little more circumspect when I'm treating resorptive conditions like internal and external resorption. If you have dislodgement, on the other hand, an ankylosed tooth would be a perfect candidate for a socket shield, because the kind of damage that you would do in trying to extract a tooth would result in disastrous effects in terms of the aesthetic outcomes. Dislodgement at the time of the extraction is a potential complication, and though it has not happened, I have never left behind a dislodged fragment. From those that have left behind dislodged fragments and gone ahead and installed implants behind those fragments, have found that as the fragments get extruded, they leave behind big soft tissue voids, and which need extensive correction with soft tissue procedures. So dislodgement would be something that you would want to watch out for. And for this reason, with as little vibration as possible, if you can have section the tooth, is the best way to go with sectioning. Over a period of time, there have been some reports of the socket shield being extruded, and this is possible again if the shield becomes inadvertently loose and it is maintained without, if you're not aware that it has loosened up. But if it does come to your notice, then you should be taking the shield out before placing your implant. You could have a dehiscence over the root fragment if the root fragment is too high. If you've left it too high above the bone and you do not have enough soft tissue to cover. So these are a few things that one would want to watch out for. And to conclude, I would say that the proof of principle that was presented by Hertzler in 2010 and the case series that have been presented by Giorgio Kotsakis and company since, and the number of case reports that have been published in literature since, they are amply demonstrating the proof of principle that Hertzler published, and it is shown to be clinically viable in several cases, and not from one center, but from various parts of the world. Particularly people that I would like to mention are people like Howard Luckman, Jorge Campos in Spain, Maurice Salama, all of who are doing who are finding great success with doing this technique. So this seems to be an exciting way to preserve the integrity of the buccal bone and with immediate implant patients. And we know now, though, that the evidence is low. We need to gather more evidence, and that would come by if more of us got together and collaborated, and that's why a forum like Dental XP is a great place to put your cases and have people look at it, and all of the data can pool together to be contribute to the science. As a cautionary note or a caveat, let us also understand that each technique comes with a learning curve, and there are a set of potential complications. And this technique should not be practiced by clinicians who are novices. It should be for those who have adequate experience doing immediate implants. And once again, thank you all for paying attention and listening to what I had to say. I can't thank Dental XP and the Salama brothers, Maurice Salama particularly, enough for giving me this opportunity. Thank you.